Good morning. Good morning, everyone. I would like to be thankful to the organizing committee for providing me this opportunity. I'll be discussing about the wound modulators in trabeculectomy. Why we need wound modulators? Previously, when they were doing plain trabeculectomy without any wound modulators, these trabeculectomy usually fails after 2 to 6 months. So, to preserve the vision, we require IOP in low teens, and main determinant for long-term IOP control is a healing response. So, and the main reason also is a fibrosis and scarring, and that leads to failure of bleb. So, to control the scarring process and give patient a long-term IOP control as well as functional vision, we need a wound modulators to prevent the scarring process. There are various factors which affects the wound healing. These are the activated conjunctiva with pre-activated cells with variety of inflammatory mediators, plasma proteins, blood cells, migration of polymorphonuclear cells, macrophages, even the aqueous released from the eyes. When the bleb starts functioning and there is breakdown of blood aqueous barrier, there are release of growth factors, specifically transforming growth factor beta. It is a very fibrotic agent and that leads to bleb scarring. And in later phase, there is a collagen cross-linking and scarring also. So, in patients with neovascular glaucoma, patients with previous failed filtration surgeries, previous conjunctival incision like SICA, CCC, or patient with RD surgery or squint surgery, patients with aphakia, uveitis, chronic conjunctival inflammation, patients on long-term topical medications, patients who are having high preoperative IOP because these patients have high level of transforming growth factor beta, and patients who are elderly and young, these are very high, these patients have very high risk risk for failure due to scarring. Antimetabolites use was based on the study that the cell culture result shows that short-term applications of antimetabolites, they arrest the cellular growth for a long term. So based on that, first Parrish et al. Introduced 5-fluorouracil regimen in trabeculectomy, and it is a pyrimidine analog which interferes with RNA and ribosomal synthesis, and mitomycin C was first used by Chen, and it is a cytotoxic agent which inhibits the DNA dependent RNA synthesis. Mitomycin is used as a single dose application 0.1 to 0.5 mg per ml diluted with BSS, and 5-fluorouracil, it is used as a single intraoperative solution 50 mg per ml, but it has to be augmented as a post-operative regimen also. The benefits of mitomycin C over 5-fluorouracil is mitomycin has a superior long-term IOP control, it has no corneal side effects, increased efficacy, and there is ease of application because they don't need post-operative augmentation. To optimize the effect, we have to optimize our choice of agent as well as perfect method, so that it should be under the scleral, I'll be discussing in the video. So here for applying the mitomycin C, we have to take care that the forceps which is held to use the mitomycin C should not be touching the conjunctival border which we have cut, and mitomycin C sponges ideally should be non-fragmented sponges. It should be applied very posterior so that we can have a posterior diffuse bleb, and it should be washed with thoroughly irrigating of 30 to 50 ml of BSS. So for Moorfields Eye Hospital has given us criteria what antimetabolites to use and how to use. So patients with low risk factors, no antimetabolites are required, or you can use 5-fluorouracil 50 milligram per ml in 5 minutes. Intermediate risk patients where we can use 5-fluorouracil 50 milligram per ml for 5 minutes, or mitomycin C 0.2 mg per ml for 3 minutes. These patients are patients on topical medication which is pilocarpine and adrenaline. Previous cataract surgery without conjunctival incision, several low risk factors, patients with combined surgery and previous conjunctival surgery. While patients who are high risk that are neovascular glaucoma, chronic persistent uveitis, what we have discussed previously, these requires mitomycin C in dose of 0.5 mg per ml for 3 minutes. 5-fluorouracil also needed as a post-operative injection. The original regimen used was of a 21 injections which were given 180° apart from the bleb. But the study shows that at least 3 injections are required for its better effect, and if you need a proper effect, minimum number of injection required was a 5. So the technique used modified was now 5-fluorouracil injections are given near the bleb with less number of injection. You can use viscoelastic to improve the long-term effect, and it should be given with a small bore needle and long track that prevents the spillage over the cornea, and that prevents the corneal side effects. Post-operative injection of mitomycin C are not used, but in needling you can use 0.01 ml of 0.4 mg per ml of mitomycin C. The drawback of these antimetabolites are because it treats relatively small treatment areas, so it can lead to thin and cystic bleb. Then there are high chances of leakage as well as hypotonia, and if hypotonia is there, hypotonic maculopathy with prolonged visual impairment can also occur. Due to thinning of a bleb, there are high chances of endophthalmitis, and if inadvertently it enters into eye, there are chances of ciliary body as well as endothelial toxicity. Ologen implant, it is a collagen matrix implant which we have discussed earlier. So it degrades within 90 to 180 days, but it gives a very controlled resistance to aqueous outflow. Other antifibroblastic therapies which are now under the studies is tranilast, Trabeculectomy. Trabeculectomy is a human monoclonal antibody to transforming growth factor beta 2, which is a predominant form of transforming growth factor beta in aqueous, and which enhances the scarring. So this acts only if the TGF beta 2 is present in the wound. Animal studies have shown improved outcome, and histologically it is less destructive to local tissue as compared to mitomycin C. Other therapy, the photodynamic therapy were previously used by some of the people. The benefit of that, it gives a very large area of exposure, so very large diffuse bleb is present with that. Matrix metalloproteinases is an enzyme which degrades the extracellular matrix. So MMP inhibitors are also in line, which reduces the scar and prevents the normal tissue. Other agents are Taxol and etoposide and cytocalcin B, which all are microtubule stabilizing agent and microfilament inhibitor. All these agents inhibits the scarring and improve the long-term outcome, but still these are under the process. Right now, what options we have is only mitomycin, 5-fluorouracil and ologen implant, but along with this careful surgical procedure, careful handling of tissues, thoroughly not doing too much cautery, and better tissue handling, all these factors also affects the wound healing. So we'll conclude with that. Thank you.
Gunjan,